All right, this is chapter 25. We're talking about nursing care of patients with cardiac dysrhythmias. So we're going to kind of set some foundations here. So we're going to talk about the cardiac conduction system. Most of the time it starts with the SA node. That is the sinoatrial node. And that's what initiates that cardiac conduction process. And typically, normal rate is between 60 and 100 beats per minute. So that sinoatrial node fires, it initiates a cardiac conduction cycle. Then it travels to the AV node, the bundle of His, the right and left bundle branches, and the Purkinje fibers. So we'll view a picture of that. So the SA node, also called the pacemaker of the heart, that's what initiates that cardiac conduction. Then it's going to travel to the AV node. So the SA node fires or triggers both atria to contract. Then it'll go to the AV node, and then it travels to the bundle of His, and then the left and right bundle branches and Purkinje fibers, which cause the ventricles to contract. So cardiac cycle is one heartbeat, and it's the electrical representation of contraction and relaxation of the atria and ventricles. So this is components of the cardiac cycle. We've got the P wave is right here. Then we've got the QRS complex. And then the T wave. And we measure different things on the cardiac cycle. We monitor the PR interval, so the length from the P wave, or from the start of the P wave to the start of the R wave, so essentially the Q. We also measure the width of the QRS complex, and then we look at the ST segment. If you remember back from our last unit, we look at the ST segment for ST elevation, could indicate a myocardial infarction. And then we also look at the QT interval as well for some different indicators. So we'll go through that. So an electrocardiogram that shows the electrical activity of the heart. There's a 12-lead ECG, which shows 12 different views of the heart. And there isn't a picture in your book, but if you just Google a 12-lead EKG, you'll show the placement of where those stickers are placed in the different view of the 12-lead ECG. And then the waveforms, they change in appearance to different leads. Oftentimes that lead 2, that is your classic that we just looked at, where the leads or where the waveforms are upright. So typically that is one that we look at quite often. This is what the ECG is graphed on. This is a 6-second strip. From here to here is 3 seconds. This is one of those boxes, and one box indicates 0.2 seconds. And then inside that, the dark red box are little red boxes, and each little red box measures 0.04 seconds. And there's 1, 2, 3, 4, 5 little boxes. This is a 5 by 5 square box. So the ECG graph paper, it's calibrated grids for measurement. Time is calibrated horizontally. Those heavy lined are in blocks of 25, so it's 5 by 5 squares. And each small box indicates 0.04 seconds, or that's how wide it is. And then those 5 small squares equal 1 heavy box, which is 0.2 seconds. So the first thing we'll talk about is an isoelectric line. That indicates that there is no electrical activity going on in the heart. There's a straight line produced, and the waves could be upright or downward from that isoelectric line. So first we'll talk about the components of the cardiac cycle. So the first little waveform that we see on an ECG is the P wave, and that is the first wave, and that indicates atrial depolarization. So the atria are contracting. Then we have the PR interval. That's something that we measure, and that is measures from the beginning of the P wave to the beginning of the QRS QRS complex, or ventricle depolarization. And that interval is typically 0.12 to 0.2 seconds. That's normal. So if it's out of those parameters, then that's abnormal. So this is that PR measurement. We measure from the beginning of the P wave to the start of the QRS complex. QRS complex is composed of 3 waves, the Q, the R, and the S. It comes after the P wave. The Q wave is the first downward deflection, with the R wave being the first upward deflection, and then the S wave is the second negative deflection if the Q wave, second negative deflection if that Q wave was deflected as well, or the first negative deflection after the R wave. And the QRS complex represents ventricular depolarization or ventricular contraction. So here is the QRS complex. This is a QRS complex showing that there is a Q wave, so a downward deflection. This B is a QRS complex without a Q wave. There's no Q wave. And this is a QRS complex with no Q or no S wave. So the QRS interval, that is the beginning of the QRS to the end of the QRS, it's normally it is less than or equal to 0.10 seconds. So this is the QRS interval. So we would measure from here to here. So if we count boxes, so one box equals 0.04 seconds, right? So we've got 1, 2, and like a fourth of a box. So that would be, this is 0.04 plus 0.04 is 0.08. Plus like 0.01. So this would be like 0.09 is the length of the QRS complex. The next wave that we see on the ECG is the T wave, and that represents ventricular repolarization, or where those ventricles go back to the relaxed state, and it follows that QRS complex. And we don't see a specific wave for the repolarization or the relaxation of the atria that is actually buried inside that QRS complex. So this is the T wave. There's T wave. This is a normal T wave with positive deflection, and this is a negative T wave, or inverted T wave with negative inflection, and that could indicate some type of ischemia going on or lack of blood flow to the heart muscle. We do measure the QT interval, which is the beginning of the Q wave to the end of the T wave, and normally that is 0.34 to 0.43 seconds. It does vary based on gender, heart rate, and age, and if it's prolonged or if it's shortened, that can lead to ventricular dysrhythmias, so we always want to monitor that. U wave. You rarely see a U wave, but we just have to mention it. But that could indicate hypokalemia, which is a low potassium level, and it will come after a U wave. So this is an example, or come after a T wave of a U wave. So it's just an extra wave in the ECG that normally you don't see. Then we have the ST segment. So that is measured at the end of the QRS to the beginning of the T wave. It could be depressed with ischemia, and it could be elevated with cardiac injury. So this is what we talk about, that STEMI, the ST segment elevation. So when that's elevated, that could indicate that there is some type of cardiac injury or a heart attack going on. So this is the ST segment. This is the ST segment that's inverted or depressed. That could indicate some type of ischemia. And this is the ST segment elevation that could indicate some kind of infarction going on. Okay, so how do we interpret cardiac rhythms? There's 6 steps to it. The first one, we determine the regularity of the rhythm. Is it regular or not? Are the beats occurring along a a similar pattern. What is the heart rate? We want to know, what is the rate? Is it between 60 and 100, the normal rate? Is it bradycardic? Is it lower? Is it faster than 100? Is it tachycardic? We want to look at the P wave next. Does the patient have a P wave? What does it look like? What do all of the P waves look like? We want to look at all of the P waves on the rhythm strip. Are they similar or are they not? Then we want to measure the PR interval. Want to look at that. The next thing we want to look at is the QRS complex. Measure that, look at those characteristics, and then look at the QT interval as well. So this is normal cardiac waves. They're equal distance apart. So these march out in equal distance apart on the EKG. So we've got a regular wave. So you can count the distance between the QRS complexes, or you can count the distance between the P waves. And typically we use calipers, they're like those little things that we used to draw circles back in geometry with, and you can just step it out to measure that it's the same. So this is counting R waves in a 6-second strip. So 1, 2, 3, 4, 5, 6. We've got 6 in a 6 seconds. So we'd add a 0, it would be a 60 beats per minute. So this is the heart rate. Is regular. We want to count the boxes between the two of the R waves. So this is indicating normal sinus rhythm, or this is a picture of normal sinus rhythm. We want to look at, first the regularity, step it out, that they're, regularly occurring at, across at the same intervals. Then we want to look at the rate. If it's between 60 and 100, then it's normal sinus rhythm. Then we want to look at the P waves again, and the P waves, they all look similar. Then we would measure the PR interval, the length from the start of the P wave to the initiation of the QRS complex, and we want that to be between 0.12 and 0.2 seconds. Then we want to look at that QRS complex, measure that. We want that less than 0.1 seconds. And then we want to look at the QT interval. So anyway. So normal sinus rhythm, the rhythm is regular, the heart rate is 60 to 100 beats per minute. Each P wave is rounded and presents before the QRS complex. The PR interval is 0.12 to 0.2 seconds, and the QRS interval is less than or equal to 0.1 seconds. Okay, next thing we're going to talk about is rhythm disturbances. So their impulse formation is disturbed, and we have a disturbance in conduction, or we have a disturbance in conduction going on. So first we'll talk about sinoatrial node dysrhythmias. So the first one is sinus bradycardia and sinus tachycardia. So sinus bradycardia, everything is normal except for the heart rate. It's slower. It's less than 60 beats per minute. So sinus bradycardia, the rhythm is regular. The heart rate, however, is less than 60. The P waves are normal. They're rounded. One comes before each QRS complex. The PR interval is normal, 0.12 to 0.2 seconds. The QRS is less than 0.1 seconds. Signs and symptoms of sinus bradycardia. Patient may not have any, or they may be fatigued and faint because their heart is not able to keep up with their oxygen demands. If they have no symptoms, we don't do anything for these patients. But if they do have symptoms, if they're fainting, if they have fatigue, typically we'll do oxygen. We'll do atropine, which will help speed up the heart rate. May do dopamine or epinephrine. Again, they'll help to speed up the heart rate. And the may do a pacemaker. So the patient may have an implantable pacemaker that'll initiate their heart to fire and contract more often. This next one is sinus tachycardia. In sinus tachycardia, the rhythm is regular, but the heart rate is elevated. The heart rate is 101 to 180 beats per minute. The P waves, they are normal. They're rounded one presents before each QRS complex. The PR interval is normal. It's 0.12 to 0.2 seconds. The QRS interval is normal at less than 0.1 seconds. Sinus tachycardia, sometimes there'll be no symptoms. Sometimes patients will have angina or dyspnea, so they'll have chest pain or shortness of breath. And the elderly may be more sensitive to having signs and symptoms and not tolerate the tachycardia very well. Therapeutic interventions treat the cause. You think about patients that have an infection, their heart rate goes up. So also we can give patients digoxin, which is going to slow down their heart rate. We can do calcium channel blockers, which those are vasodilators, but they also help to slow down that heart rate. And then beta blockers, they help to slow down the heart rate as well. Okay, so next thing we're going to talk about is atrial dysrhythmias. So these are dysrhythmias that occur in the atria. And there's three different things we're going to talk about. Premature atrial contractions, atrial flutter, and atrial fibrillation. So this is premature atrial contractions. So this is where an atrial contraction comes a little bit early. So you see these funny ones that are kind of sticking out from this underlying normal sinus rhythm. So the rhythm, the pre-atrial contraction interrupts the rhythm. So we've got a premature atrial contraction that doesn't go along with the regular heart rate. The heart rate, you look at that underlying rhythm. What's that underlying rhythm? You don't really count those premature atrial contractions. The P waves, they'll come early, and that P wave will be abnormally shaped. It won't be like the other P waves that are going along with the normal rhythm. The PR interval, however, is usually normal, and the QRS interval is normal, less than 0.1 seconds. PACs, or premature atrial contractions, typically patients won't have any signs or symptoms. Therapeutic interventions, typically they won't do anything. If the patient doesn't have any signs or symptoms, may need to treat the cause. Also may need to give patients beta blockers, which will help to slow down that heart rate a little bit if that's causing a quicker heart rate. This next one is atrial flutter. So those atria are not contracting normally, with one good force. They just are kind of fluttering. And this is a 4-to-1. So we've got the atria fluttering 4 times before one ventricular contraction. And one thing to make note of, see how this is regular. These are regular. They're marching out at a regular pace. So the rhythm, the atrial rhythm is regular. The heart rate does vary, but typically it's within a normal rate. The P waves, we'll have F waves, or flutter waves, and they're in a sawtooth pattern. So the atria will be fluttering multiple times per, the QRS complex, per one QRS complex. PR interval, we can't measure it because we've got all those F waves. We've got the QRS interval is less than 0.1 seconds. Signs and symptoms of atrial flutter, that ventricular rate, if it's normal, then they'll have none. However, if a patient does have a rapid ventricular rate along with that atrial flutter, the patient may have palpitations, they may have chest pain, and they may have shortness of breath. So therapeutic interventions to slow that heart rate, we can do cardioversion, where we'd shock that patient's heart rate and just stop it for a minute, and it might put them back into, or not even a minute, just like seconds, and it'll put them back into a normal rhythm. Can do calcium channel blockers, which will slow the heart rate, beta blockers to slow the heart rate, and digoxin to slow that heart rate. This next one is atrial fibrillation. So you notice the there's no distinguishable P waves like there was in atrial flutter, and look at how irregular this heart rate is. So those are some of the differences. That there's no distinct P waves, there's just fibrillation going on. So they're not even fluttering, those atria are just quivering. And then we've got an irregular ventricular depolarization, or ventricular rate as well. Oops. So P waves, there's no identifiable P waves, those atria are just quivering. That PR interval, there's none to be measured because we don't have distinguishable P waves. And the QRS complex is normal. It's less than or equal to 0.1 seconds. So signs and symptoms of atrial fibrillation, a patient may have palpitations and they may have a faint radial pulse if it's elevated and uncontrolled. Therapeutic interventions, patients may have synchronized cardioversion. So that means is we'll tell the machine when to stop that patient's heart. Medications may be digoxin, maybe beta blockers, maybe calcium channel blockers, maybe amiodarone or adrenadrone or Coumadin. And Coumadin we would give because, the patient's atria are just fluttering. They're not contracting, so that blood is pooling and they're more at risk of blood clots. This amiodarone actually is a medication that stops that heart for just a second, again, to hopefully pick up a normal rhythm then. Beta blockers, calcium channel blockers, and digoxin are going to slow that heart rate down. Therapeutic interventions, we can do an ablation. So, the atrial fibrillation is caused by, multiple different foci or multiple different areas on the atria that are telling the atria to contract. And it doesn't because it is getting all these mixed signals. So we could maybe ablate that area that's telling the atria to contract. Can also do pacing or biatrial pacing. Where we put a device on that patient's chest that tells the atria when to contract. Can do implantable atrial defibrillator, same thing, or surgical maze procedure. All right, so we're going to move on to ventricular dysrhythmias. So the three things that we're going to talk about are premature ventricular contraction, ventricular tachycardia, and ventricular fibrillation. So one thing to make note of is all of those atrial dysrhythmias that we talked about, they're still a perfusing rhythm. So they're still going to be able to initiate or get enough blood flow to the organs and tissues, generally. However, ventricular dysrhythmias, on the other hand, may not. So this first one is premature ventricular contraction. So you see the heart rate is just marching along here, and then we've got a ventricular contraction that comes early. So just where those ventricles contract. And you see how this is a narrow QRS complex. So that's a premature ventricular contraction right there. And these ones look the same. So they are coming from the same initiation, the same place in the heart. And you see how these ones look differently. So they're coming from different areas of the heart. So this is called bigeminal PVCs. You see we've got one regular heartbeat and then a PVC, one regular PVC. So this is bigeminal. Every other heart beat is a PVC. So there's bigeminal, there's trigeminy, where a PVC occurs every third beat. There's also quadrigeminy, where we've got a PVC that occurs every fourth beat. So anyway. So premature ventricular contractions. So the PVC interrupts the regular rhythm. The heart rate is the underlying rhythm. P waves are absent prior to the PVC, prior to that premature ventricular contraction. And hence there's no PR interval for that PVC. And typically those PVCs are greater than 0.10 seconds, so they're abnormal. Signs and symptoms of PVCs include palpitations. Patients also have fatigue, dizziness, and severe dysrhythmias. Therapeutic interventions, typically there's none if they're asymptomatic, but if they have issues, then we can give them amiodarone or beta blockers. All right, so this next one is ventricular tachycardia, or VTAC as we call it. This can be a perfusing rhythm, or it may not be a perfusing rhythm. I don't know, it depends on the patient. So the rhythm is usually regular. The heart rate will be between 150 and 250 ventricular beats per minute. Slow VTAC is less than 150. There are no P waves, so there is no PR interval to measure, and the QRS complex is greater than 0.1 seconds. Signs and symptoms of VTAC include dyspnea. Patients will have shortness of breath. They'll have palpitations. They may have lightheadedness. They may have angina or chest pain, and they may go into cardiac arrest. So therapeutic intervention, if it's pulseless, so if they present with a VTAC on their EKG and you go to that patient because you need to be running to that patient right away, and you check their pulse and you can't find a pulse and they're not talking to you, you need to initiate CPR right away. And then possibly could do defibrillation, vasopressors, or antiarrhythmics. Typically, you'll just do CPR. If the patient is stable, typically, or they may do amiodarone or consider giving that patient magnesium if that was the cause of the VTAC. So this next one is ventricular fibrillation. So the ventricles are just quivering. They are not contracting. They're forcefully. They're not. This is not a perfusing rhythm. This patient is not going to be this. So the rhythm is chaotic. It's extremely irregular. There is no measurable heart rate. There's no P waves. There is no P wave interval. And the QRS interval, you can't measure that either. Signs and symptoms, your patient is going to be unconscious. They're not going to have heart sounds. They're not going to have peripheral pulses. They're not going to have a blood pressure. They do not have a perfusing rhythm. They will be in respiratory arrest. They will be cyanotic. They'll be blue. They will have dilated pupils. Need to initiate ACLS protocols, which is advanced cardiac life support. Need to be giving them CPR right away, and then typically that goes into cycles of giving epinephrine, vasopressin, amiodarone, possibly magnesium. Also may do endotracheal intubation as well, because remember the patient will be in respiratory arrest. They'll need to either be given mouth-to-mouth or bagged or intubated. Next one is asystole, flatline. We've got nothing going on for that patient. Therapeutic interventions are CPR. You'd initiate CPR again on this patient right away. ACLS protocols would also be implemented where patient would be intubated, maybe do epinephrine, vasopressin, or atropine. Cardiac pacemakers. There can be external and temporary pacemakers for patients. We can do internal and permanent pacemakers. We may override dysrhythmias. They can generate an impulse and they can be placed in the atria, ventricle, or both and initiate heart beats. Here is a dual chamber pacemaker. So we've got one going to the atria and one going to the ventricle. So these are pacer spikes. So this is the spike and that initiates the atria and ventricles to contract. So we've got one spike per every heartbeat here. So there are some pacemaker problems. It can be failure to sense, failure to pace, or failure to capture. Nursing care for pacemakers need to monitor the ECG. Patient may need to rest for several hours and monitor their apical pulse and their symptoms. After patient has a pacemaker implanted, they need some education. So incisional care, also how to take their radial pulse, any symptoms to report. They need to have an ID card, and then they need to know things to avoid as well. So they will trigger metal detectors. They need to make sure that they use grounded appliances that are safe, and they will be required to do periodic pacemaker checks where they, may need to call in or whatever. Defibrillation, that is electrical shock delivered to reset lethal ventricular rhythms. So defibrillation is indicated for pulseless ventricular tachycardia as well as ventricular fibrillation. So if the patient's rhythm is showing VTAC on the monitor, but you can't find a pulse on that patient, you need to defibrillate them. If they're in ventricular fibrillation, of course, if they're in their room or whatever, go into their room immediately, check the patient, and then they may need to be defibrillated also as well. So as far as defibrillation goes, we use conductive jelly or saline pads. The paddles are pressed firmly against the chest. They are placed in the second intercostal space to the right of the sternum, and then the anterior axillary line and the fifth intercostal space. So basically, the right side of the chest and then below the armpit on the left side. You need to announce clear, and then typically, or the way the energy is delivered is measured in joules, and typically you start low and you go high from 200, 300, 360. Here's placement of those paddles so that that electrical shock can go across that heart. Their synchronized cardioversion allows the R wave to be sensed for appropriately timed delivery. So this is used in dysrhythmias when the R wave is present. So it could be ventricular tachycardia with a pulse, atrial defibrillation, atrial flutter, supraventricular tachycardia. You do want to make sure that you sedate that patient to make that a little bit more comfortable for them. It would be, 25 to 50 joules of energy that would be delivered to that patient. There used to be a patient that would come in oftentimes where I worked, and he would present with a supraventricular tachycardia, and so that's a normal sinus rhythm, but it's very fast. He would be short of breath, all of that. He would need to be cardioverted. So we'd pop an IV in, sedate him, and deliver a shock, and he'd jump out of the bed and go back down, and then he'd be fine. He'd have a normal rhythm again. So automatic external defibrillator. It's an external device that automatically analyzes rhythms, automatically delivers or prompts the operator to deliver electrical shock if a shockable rhythm is detected. So that would be VFib or VTAC. There's also implantable cardioverter defibrillators. So this is like an implantable pacemaker that also has a defibrillator with it. So it automatically defibrillates that patient when a lethal rhythm is detected and it's already implanted in that patient. So it cardioverts when ventricular tachycardia is detected. So this is implanted cardioverter defibrillator. Nursing diagnoses for dysrhythmias include decreased cardiac output, ineffective tissue perfusion, activity intolerance, anxiety, and deficient knowledge. Make sure you read through those and some of the nursing interventions.